So good afternoon again to everybody. My name is Derek Spencer. I'm the director of the Jacques Initiative at the Institute of Human Virology, University of Maryland School of Medicine. And I just want to welcome you to this summit, this University of Maryland Leadership in HIV Summit. We are really humbled at the response of registration and the attendance here today. I understand that there may be some people who might be listening in an overflow room in the School of Nursing, so we appreciate where you are and consider you to be with us here right now. The summit here today has been sponsored by some of the work of a funder named Gilead Sciences, who's sponsoring a national program that stands for Front Lines of Communities in the United States. And the program is all about kind of normalizing, integrating, and routinizing HIV testing in hard-hit cities like Baltimore. We believe we have a very creative project, and it involves both our academic campus and our clinical campus. And today you're going to hear about that program. We have three basic goals here today. We want to educate you on the HIV epidemic and the efforts of this university. This summit is very unique because it's about our campus. It's about our approach, the University of Maryland's approach to address the national HIV and AIDS strategy. So we want to give you the information that you need to know so that you can become a part of that. We want to empower you with knowledge and tools and resources. We're happy to be releasing all types of tools, an app today, a website that you'll be able to access so that you can use in your work as you engage with the community. And finally, we want to engage you right where you are with what you do and help you to understand that what you do makes a difference. Each objective is designed to help us develop this strategy, and we realize that we're going to need a multidisciplinary, interprofessional approach, and today is a representation of what we believe with both the community, the academic community, and the clinical community who's gathering together. Our ultimate goal is to better serve our community, and to help us do that, we have asked a well-known leader of our community to serve as our master of ceremony. Deborah Hickman serves as the CEO of Sisters Together in Reaching, which is better known as STAR. Debbie, she's well known in the community, runs one of the oldest AIDS service community-based organizations in our city. And I've asked Deb to come today in a unique role as a member of the community who will witness our efforts as a university to make a difference in this HIV crisis. At this time, I'm going to ask you to welcome Ms. Deborah Hickman. Thank you, Derek.
Thank you, Derek, for that introduction. And it is really an awesome sight from where I stand to look out and to see all of you, the leaders, for this day and for days going forward. As we are marching forward with the Affordable Care Act and all of the other things, this is the appropriate time to host a leadership summit. And to keep us on time, I am going to stay to tasks that I have been given, and I have the honor to be here today, but also I have the honor to witness the greatness of this university, as well as to introduce our next guest speaker, who will be bringing us greetings, Dr. Anthony Layman from the University of Maryland School of Medicine. He is the Senior Associate Dean for Clinical Affairs, Professor of Psychiatry.
Good afternoon. Can you hear me all right? Yeah, okay. It's a pleasure to be here to represent Dean Reese and the faculty of the School of Medicine to welcome you all here. I want to particularly acknowledge at the beginning here the presence of Bob Gallo, the director of the Institute of Human Virology, Bill Blattner, and also Bob Redfield, who I understand is not. Is Bob here? No. Yeah, right. But anyways, I'm trying to. This one here? This one here. Start over again. Okay, and thank you very much. So on behalf of Dean Reese and the School of Medicine, it's a pleasure to welcome you all here this afternoon. I'd particularly like to acknowledge the presence of Bob Gallo, the Director of the Institute of Human Virology, about whom I'll have some things to say in a few minutes. Also Bill Blattner, as well as Bob Redfield, who could not be here today, but these folks have really provided the essential leadership to the Institute of Human Virology for a long time. Also want to thank Derek Spencer and Jamie Mignano for pulling this together. I know I talked with Derek last week, and I know he had a very busy week, and I'm sure Jamie did also. And thank you very much for organizing this. I think we ought to give them a round of applause. So the Preparing the Futures Initiative and the Jacques Initiative really exemplify what the University of Maryland, this campus, is all about. It's a multidisciplinary program and initiatives. This, as you'll see upstairs if you haven't already, that pulls together activities from the various schools on the campus to really provide the kinds of comprehensive care and caring for people living with HIV. And we're very proud of this, and we're very proud of the Institute of Human Virology and these initiatives for exemplifying that. The strategic vision really of the school, and I think of the campus, is to do translational research that really takes new discoveries from the laboratory, translates it into changes in treatment programs, which in turn impact the local community and the world. And I think these programs that we're going to talk about today, I can't think of a better example on campus that exemplifies that translational approach to work. And so I think you're going to have a great afternoon here. We really appreciate you all being here. And I'm going to move directly into introducing somebody who needs no introduction. It's my pleasure to introduce Bob Gallo, who's the Director of the Institute of Human Virology. Bob came to the University of Maryland in 1996 to establish the Institute. Prior to that, he was at the National Cancer Institute for, I think, about 30 years. And it's really stunning to read what he's done. I mean, I remember, I'm old enough to remember at the time when we didn't know about HIV. And I remember when my first friends and colleagues died from HIV at a time when we really didn't know anything about it, except it was a very frightening illness, and it just seemed like a death sentence, to be honest. And Bob, through his work at NCI, initially made some basic discoveries of interleukin-2, which opened the doors to the study of human retroviruses. And then in a series of discoveries by his team, HTLV1, which is a cause of some forms of human leukemia, HTLV2, and then the HIV virus really transformed the world. And then developed a blood test to detect HIV, and has continued over all these years to develop greater knowledge about how HIV interacts with the body, which in turn reveals ways to develop novel treatments that not only substantially improve the lives of folks who are infected, and we see today now that really folks can live with HIV for a full life, which is a stunning change compared to when I first encountered HIV, and also hopefully eventually both the cure of HIV and the prevention of it. And I think really, Bob, we're very grateful to you for all this work that you've done. It's really quite amazing. Bob is a member of the Institute of Medicine of the National Academy of Science. He's received over 30 honorary degrees. He's published over 1,300 articles. Something I didn't know about Bob, he's a member of the National Inventors Hall of Fame. And he was cited between 1980 and 1990 as the most cited scientist in the world by the National Institute for Scientific Information. And from 1983 to 2002 is credited as the third most influential scientist in the world. So we're very honored as a university to have Bob here. We're very honored to have him as a speaker today, and very honored just to be here. So thanks, Bob.
Thank you. Thanks a lot for your time. Thanks, very kind. On behalf of the Institute of Human Virology, with the Jacques Initiative, I guess we should say welcome to to everyone. And I also want to acknowledge Jeff Crowley. I haven't seen him in some time, but he was a key part of the President Obama's first term in the AIDS office. I don't know the official name of the AIDS office. You can talk about it later. But also played a leadership role in these more recent years. 17 years ago, we formed, as you already heard from Tony, the Institute of Human Virology. I was the co-founder with Bill Blattner, who heads our epidemiology and public health preventive medicine division. And Bill was also the commissioner for AIDS in Baltimore. That's no longer in operation now, but he helped align the national plan from the president to Baltimore in its own style and way, I think, and unique aspects in some respects. Bill also has an enormous program in Nigeria, and a lot of what he did was the comparison of West Baltimore to West Africa. But that's a story in itself, and I'll be here way too long. Bob Redfield is not here because he's receiving a clinical reward in New York for what he's done in HIV therapy. The Institute has really developed well. We're over 300 people now, I think about 320 people. In a very difficult time, we're doing okay. So we have basic science and vaccine, and we have clinical division, and we have epidemiology and animal model, 4 divisions. Within the clinical division that Bob Redfield heads is the place we talk a lot about in this meeting in particular, namely the Jacques Center there. It started, I guess, as an outreach program from the clinical division to the area to try to make people more aware of the disease. And it became more and more sophisticated in this regard with the great help of this man who died prematurely of AIDS, Dr. Jacques. Well, actually, he told me his real name wasn't Jacques. His name was more ending with a vowel like mine, but we won't go into that. I don't know what's true and what's not true because Derek never told me details. But let me say that the Institute has a gem led by Derek for many years now, the Jacques Initiative. And again, I don't think I should do a review of that because I'm not good enough to do a review. But it's been so innovative in the outreach kind of program and in the getting information to people that need this information, that testing and treating is a key to this epidemic. Derek suggested that I say a few words about all the practical advances have come from basic science. So yeah, I had the basic science division and vaccine development with George Lewis in our institute. It's almost true, but not 100% true. I say it to sort of brainwash Derek and some other people, but it's not 100% true. So let's just summarize the story of where we are. 100 to 200 years ago, HIV came into man. Unfortunately for people in Africa, the primates, the monkeys and chimpanzees in Africa, as opposed to monkeys, primates in South America, or monkeys in Asia, all of whom use primates for food. Unfortunately, the primates in Africa carried the relative of HIV, namely the Simian immunodeficiency virus, which in many of those primates doesn't cause any problem for them. They've adapted to it. But if you follow them long enough, some of them will get AIDS. This was, of course, unknown. HIV knowledge came first. We didn't know about the monkey story. So how did the virus get into man some 100 to 200 years ago? In apparently a single isolated case. It can be traced by brilliant work of my former postdoctoral Beatrice Hahn, who I sponsored for the National Academy of Sciences, not the Institute of Medicine, but the National Academy, which I am a member of. And she got in more rapidly than I've seen anyone get in. She really defined the type of chimp, the exact location, and then HIV-2 we've already known is from a West African monkey called the Sudi Mangabe. And she typed it to a single transmission. These are hunters, and the hunters clean animals and they get caught, and virus moved from animal to man. They also, when the animal's not dead, get bitten, and we know that that's another route of transmission potential. So how many times did a transmission occur? We don't know. It happened in the rainforest. And did people get sick earlier than that? We don't know. They would have died with their disease in the rainforest. That's not an epidemic. That's not really a big problem. It's an individual problem. So, but apparently one particular Simian immunodeficiency virus from a chimpanzee in likely southeastern Cameroon and into the Congo area, that region of animals had some Simian immunodeficiency viruses that quickly moved towards the ability to infect humans. and once in humans was able to go from human to human by the transmission of fluid, bodily fluid. You can't get it easy. You don't have to be afraid of a person with AIDS. We knew that at the beginning because the first contributions in science to this disease were really not from the basic science. They came from American clinicians on the east and west coast of the United States who identified the disease and told us that it was probably a disease of this critical cell of the immune system we call the T cell, particularly the T helper cell. That's the beginning that makes you think. And secondly, the epidemiologist at CDC made the second important contribution, and that epidemiology was the risk factors were blood, sex, mother to child. In other words, being born of an infected mother, milk transmission particularly, but other ways as well. And then you have that background. Something like that stimulated the notion to Max Essex at Harvard School of Public Health and myself, we were friends, that this might be another retrovirus disease. There's no time to go into why we had that reasoning, but suffice it to say the human retroviruses we knew of already were transmitted by blood, sex, and mother to child. They targeted T cells. That was enough. And so that began the idea that led to some productive research. There were many other ideas, some of them completely wild and rather stupid. But that's the way it goes in science. We get all kinds, even from very intelligent people, some ideas were not well thought out. So there was a struggle at the beginning to accept the idea that this might be due to a retrovirus. So how am I going to prove that? When we began, and a French group began to detect this kind of virus in man, in some association with AIDS patients, but we couldn't find it all the time. And you could say, if you're a critic, well, really, when a person has AIDS, because you don't know them, there's no test. All you know is when a person is sick and dying almost. How do you know it's not one of the other microbes that they've got with them? Prove it. How do you prove that? At that time, we didn't have therapy, we didn't have anything. So we knew that finding the virus was going to be difficult for other people because by the time a person had AIDS, they had hardly any T cells left in their blood. And what do you get for samples? T cells. We also knew that many labs were afraid to work with it. And thirdly, we knew that many labs would not have this kind of competence to culture human blood T cells with interleukin-2, a factor we had only discovered in the mid-late 1970s. So we needed something else. We're starting to get more and more of these virus detections and isolations, we call it, in a laboratory, as did the group in France. But, you know, I said this is never going to be enough because it won't be verified. Verification is critical in science for a field to go forward. We needed something else. That's the blood test, the HIV antibody test. It also, when we developed it, preserved our blood supply. It stopped people like hemophiliacs who receive blood regularly, or anybody who goes to surgery who gets blood were threatened. There was a really significant incidence of blood contamination. Let me give you an example. In Japan, we tested blood there with the antibody test in around, let's say, let me be more precise, I think it was February 1984, and nobody in Tokyo was positive in the hemophiliac community. But 2 to 3 months later, 20% of their clinic was positive because they don't give blood in Japan, at least not at that time. They take blood from Europeans and from Americans. And that's how fast it came. So it was really moving. If we didn't get a blood test, I've often asked this, and I have no answer to it. I don't know what would have happened. But all the people who get infected and don't know they're infected are infecting other people. It would have been a truly, truly enormous problem. So how did we make the blood test? Well, we knew we needed one. We knew we had to protect the blood supply. And I knew also I wanted it to convince people this is the cause of AIDS because I want something fast, simple, sensitive, inexpensive, rapid. That's the blood test that we made. But to do it, how do you get enough material to send to the world, to get verification everywhere, to have the blood test everywhere? We had to be able to produce this virus in large quantities. My technician, Betsy Reed-Knoll, and independently and working with Betsy, Nika Popovic, who's still at the Institute now, he came with me from NCI. We're able to produce the virus forever in a certain T cell that grows forever in the laboratory. Nobody could do that before. It was a dramatic breakthrough for us. That's the only time in this whole disease I think I smiled or felt a feeling of eureka. You know, you press people always ask, what, you know, do you have parties? Do you celebrate when you have an advance? With HIV, there's never any moment like that because slowly you're learning. And when you have an advance, you're always thinking, oh my God, there's also this by tomorrow, you got this other pressure. So there's never that moment of pause and reflect and happiness. But this one, when we knew we could grow the virus, we knew it would be all over soon. We knew that we'll be able to prove this one way or another and fast. because we'll have enough material to make a very sophisticated, wonderful test. That's the HIV antibody blood test that's still around now. So those advances, yeah, they came from basic science, because basic science gave us our ideas. Basic science gave us our ability to grow human blood T cells. Basic science allowed us to transmit this virus in the way I just talked to you about, in a cell permanent growing line to mass produce the virus. Verification became rapid, and verification came globally, and this was accepted as the cause of AIDS by all the reasonable world. It also provided a system that we could test drugs. Now, in the midst of all this, Betsy Reed Knoll, who did a good part of this work, ironically, her husband died of AIDS. He was a hemophiliac, and we didn't have the test in time. So we worked fast. But every time I think back, and I'm not pretending this to look like it's a moment of false humility, it is really true that when we think back, we think of all the ways we could have been faster. Because you know the person, particularly our husband. I said, boy, if we'd only done this, if we only yelled louder earlier with the HHS, why were we not taking our own, do what you think is right yourself. Don't worry about it going all the way to the top administratively. We were too worried about the next level. We got to, going up the line. We knew the cause. We were sure of the cause by, I would say, not later than January of 1984. With some real certainty. The papers weren't published till early May of '84. So one last thing is, how did the virus become epidemic, and where do we want to go in the future? So two remaining things. The virus became epidemic in my mind because of the changes post-World War II. The airplane, tourism, increase in sexual contacts, more global contacts, maybe increased number of contacts, and blood, as I told you already, being shipped from one nation to another. So what was once remote and uncommon became global. But how did it first kindle in Africa? We don't know the full reasons for that, but sociologists and historians say when imperial powers created roads and trucks were moving up and down those roads, but in addition, problems occurred with war and famine, and there was an increased movement to cities. So you don't have an epidemic until you don't have a fire until it's kindled. You don't have an epidemic until it's kindled. You have to have a certain concentration of infected people before something can spread. But very quickly, as I said already, a remote infection became a global infection. What was uncommon became relatively common. So today we know what we need to do, right? We're involved in other viruses, not just HIV, and I've returned to some extent to some basic cancer research, looking for other infectious causes of cancer. Even HIV itself indirectly can increase the incidence of cancer, so we work on that too. But we know what we want to do is eliminate HIV, right? And you'd like to try to bring people who are chronically infected to a still better and better end point. So I don't like using the word cure, because most of the time I think it leads to some false hope and misinterpretation of data. But we certainly want to make infected people have the virus go away if possible, or at least have therapy that is better and better and better. But we want to eliminate the epidemic, right? So our institute's involved in a vaccine which is supported by Gates, which will start phase 1 trials next year. But in the meantime, and if that doesn't work, and if it works imperfectly, of course we need other things. Of course we need education, but it's been proven, as you could think with your own head, that will never be sufficient alone. So there are things like microbicides, but there's nothing better than what you're doing. The answer is to test, 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 and we've known that for a long time. But it's now becoming something assertive by government and by cities. Not just here, but in many parts of the world, perhaps almost all over the world. Lots of testing and lots of early treatment. We do that, we lower the virus in an individual. All biology is quantitative. If I'm infected and I have this much virus and I'm in contact with someone, good chance of transmitting. Forget statistics, it's only one in a few X hundreds and hundreds of contacts. If I'm viremic and it's high, the efficiency of transmission is quite nice. Don't worry, that virus will get across. So, but if we treat early, test a lot, lower the amount of virus, the chances of transmission are very, very poor. Thus, the epidemic would wane and maybe go out of existence. That's the hope. That's why what you're doing in outreach in a community that has a high level of infected people cannot be more important on, what's today's date? November on November 4, 2013. Nothing is more important. Therefore, this meeting, this program of the Jacques, what Jeff Crowley will talk about, these things cannot be more important than the HIV epidemic. I thank you from the Institute for all the things you do to help us and the whole campus in this regard. And I thank the other schools, not just medicine, such as the law school. And, well, I'm not going to go through all the schools in the campus, but it's the first time I've ever seen anything like this happen. And it's a great thing. And Derek, congratulations for this to you and your staff for playing a very central role in all of it. Thanks.
3 years ago, President Obama released the National HIV/AIDS Strategy. The strategy is the nation's first comprehensive, coordinated approach to reducing the number of new HIV infections, increasing access to care, and improving outcomes for people living with HIV, and reducing HIV-related health disparities.
The President is committed to a national HIV/AIDS strategy that is grounded in the best science, which now tells us that early treatment is better for the individual's health, and treatment can also reduce the risk of HIV transmission by as much as 96%. So treatment is also prevention.
Since the strategy was launched, there have been many new scientific and policy developments that are helping us to move forward. These include a deeper understanding about how people living with HIV in the United States are accessing care and how that care affects their long-term health.
Of the more than 1 million Americans with HIV, only 82% know they are infected. That means 18% are unaware of their infection. That's more than 200,000 people. 66% were linked to HIV care. 37% have stayed in care. 33% are receiving treatment. And only 25% have the virus effectively controlled, which is necessary to maintain long-term health and reduces the risk of transmission to others.
The ultimate goal of HIV care is to suppress viral load, but only 1 in 4 people living with HIV makes it all the way through the care continuum to achieve that goal.
So our challenge is that not all people living with HIV are getting the full benefits of treatment.
In light of these new developments, today the President issued a new executive order directing federal agencies that implement the strategy to accelerate efforts to increase HIV testing, enhance linkage and engagement in care, and improve treatment outcomes. These actions will help us reduce the drop-offs along the HIV care continuum and help us meet the goals of the strategy.
And by meeting the goals of the strategy, people living with HIV will live longer, healthier lives.
As a person living with HIV, I understand these challenges. There's no simple solution, but we can use this opportunity to do better, to feel better, and to live better.
Together, we will identify opportunities to address gaps and barriers and improve outcomes along the HIV care continuum. This initiative will engage the federal government,
Researchers,
Providers,
and people living with HIV and others to work together to accomplish the goals of the strategy.
So we've got to keep pushing. We've got to make access to healthcare more available and affordable for folks living with HIV. We've got to implement the protections in the Affordable Care Act.
Each of us has an important role in national efforts to improve the HIV care continuum. Each of us can help to make the 1 in 4, 4 in 4.
Thank you so much. Can you guys hear me? No, we're challenged. Okay. Again, can you hear me now? Thank you for your patience. I'd like to talk to you for just a couple moments before you start hearing about what we have achieved here on our campus from the theme, a time to use big words. I believe that we're in a moment in HIV history, and every moment requires an equivalent movement. And what we're doing here on our campus is about movement. Let's talk about some big words. In 2011, the World Health Organization and UNAIDS adopted as a theme for World AIDS Day, getting to zero. Zero new infections, zero stigma, and zero discrimination or stigma. Big words, hard to swallow in a city like ourselves that is so hit hard with HIV, but it's time to use big words. In 2010, under the leadership of our speaker today, who you'll meet very soon, a team of people came together and developed our nation's first national HIV and AIDS strategy. The strategy has 4 basic components. The first component is to reduce new HIV infections. Secondly, to increase access to care and improve health outcomes for people living with HIV. Thirdly, to reduce healthcare disparities, and something we feel very passionate about here at the Institute of Human Virology is to achieve a coordinated response. And so today in this room, again, represents the best of our campus, both academic and clinical, partnering with the community to make a difference. The vision of the National HIV and AIDS Strategy is an example of using big words. Let's take a look at it. The United States will become a place where new infections are rare. That's a big word. And when they do occur, every, that's a big word, person, regardless, that's a big word, regardless of age, gender, race, ethnicity, sexual orientation, gender identity, or socioeconomic status, will have unfettered access. I have been asking audiences, and I want to ask you, when is the last time you used the word unfettered? It's a big word. Unfettered access to high-quality, life-extending care, free from stigma and free from discrimination. Another thing that we have noticed recently is the use of the big word and age-free generation. And this issue is something that came about when we started hearing in 2011. Hillary Clinton stood before the United Nations and talked about the possibilities because of the advancements in science, because of medical advancement, that we could potentially have an age-free, not stop the HIV crisis, but prevent people from advancing to AIDS through early testing and early treatment. We had our president in 2011 on World AIDS Day stand before a global audience and again use the big words talking about an age-free generation. So we have incredible opportunity, but we also have incredible challenge. Let's consider the challenge that is before us. We know and so grateful for some of the things that Dr. Gallo said, even with how HIV was spread, some of the issues in our cities. And what you're looking at is some data of how HIV tracks with social and economic disparities. And what you're looking on this graph are issues with high school education, unemployment, poverty level, and homelessness. And what you see is there's a higher prevalence of HIV associated with lack of a high school education. There's a higher prevalence of HIV that's associated with unemployment. There's a higher prevalence of HIV associated with living below the poverty level and also being homeless. And so many people may wonder, why do we gather this multidisciplinary team? Because the work and your passion, if your passion has to do with community, if your passion has to deal with young people and getting them through high school, if your passion has to do with substance abuse and mental health and housing, you are an agent for HIV prevention. Maryland ranks number 3 through 2011 and ranked by rate cases of HIV, and our city, for as long as I have been practicing, has remained in the top 10. In our city of Baltimore, 1 in 40 people over the age of 13 is living with HIV. Amongst African Americans, that is 1 in 29 over the age of 13 has HIV. And in this zip code where we practice the best medicine, where we have the best faculty and leaders in education, research, and science, in this zip code, 1 in 23, 1 person out of 23 over the age of 13 is living with HIV. Can you just pause And just imagine standing outside of this campus center and watching the crowd go by and go 1, 2, 3, 4, 20 positive. 1, 2. We have an incredible issue in this city as it relates to HIV, and we believe that it's time to use big words with big approaches. This continuum of care is something you're going to be using a lot today in your breakout sessions. We have about 15,000 people living with HIV, only about 82% of them diagnosed. That takes us down to 12,000. Not all of them linked into care, not all of them retained in care, not all of them on medicine, which equals not all of them suppressed. And so we need this to not be 1 in 4, but this needs to be 4 in 4. We need HIV infection to equal viral suppression. So you heard from Dr. Gallo that for a person who is on medicine and suppressed, very difficult for them to spread virus. So we want every discipline on this campus and our clinical expertise, whether it's acute or outpatient, to be an entry point. And so what am I saying? We see the School of Pharmacy and your expertise, the School of Dentistry, the School of Law, Social Work, Medicine, and Nursing. Each of these schools and our clinical partners in the hospital and outpatient centers as an entry point for people to be tested and also to be linked into care, particularly through your community engagement. Our campus has an incredible opportunity, and this fits so well within our strategic vision as a campus to address and partner ourselves with the community and do great things. There are a couple things that have been game changers, and part of that came out of some 2006 recommendations for routine testing. There was a slow uptake for this, but in 2000, just this year, the United States Preventative Task Force upgraded routine testing from a grade C to a grade A, which lifts its ability not only for billing, but starts to rank it at the same level as testing for cholesterol and lipids and prostate and doing things like mammograms. In 2011, this was declared as the science breakthrough of the year, that HIV treatment is prevention. In a study called HPTN 052, looking at about 1,800 couples, serodiscordant, one was positive and one was negative. People were randomized to receive early treatment with a CD4 count over 350 or delay their treatment. There were 28 transmissions of HIV to uninfected partners. 27 out of 28 happened when the partner was treated late. What's good for the patient is good for the community. What's good for Magic Johnson is good for Cookie. What's good for the mother is good for the unborn child. When we do a good job with our clinical expertise, with our academic expertise, whether it's law, social work, medicine, nursing, pharmacy, nursing, whatever that expertise is, when we do a good job for the patient in front of us, we do a good job for the community. There are always 2 clients before me in the field of HIV. There's a client I see, and behind them is the community they represent. When I do a good job for the patient, I do a good job for Baltimore. And this can't be that we have excellent treatment and it's all about the Evelyn Jordan Center, it's all about Maryland General, or it's all about the Jacques Initiative. That is not enough. We have excellent clinics, but if you want to change a city, you must engage the city. And so on purpose today, we have invited you because you are needed. It is not nice that you're here. It is necessary that you're here. So today we want, by the end of this session, we hope that you clearly can articulate what is your something. You may have interest in women's health. You may have interest in kids graduating from high school. I showed you the data on health disparities and these social determinants of health. Whatever you have to offer, it will make a difference. I close with this. We're not called to do everything. but we're called to do something. What is your something? We want it. We need it. Please share. To give you details of what we have accomplished together over the last year, I want to introduce to you a woman who's probably one of the most hardest working women that I've ever met in my life. We're fortunate to have her on staff at the Jacques Initiative. Her name is Jamie Macdonald. She's the Director of Development and Information Dissemination. Please welcome her as she comes forward.
Thank you, Derek. And thank you to everyone that's gathered today. We are truly humbled by the audience, and we're very, very grateful that you've come to hear about the work that's been done on our campus by all of you. I'd like to say thank you to the faculty that have collaborated with us over the past year and a half with our Preparing the Future program, and the clinicians from the University of Maryland Medical Center and the dental clinic that are here. The information that I'm going to share represents our work, our collective work, and the work of the 500 students that have been trained in the Preparing the Future program. In 2009, we developed this model called the community engagement model. We've envisioned that in order to address the HIV epidemic in Baltimore, that we needed to work together. We started out by working very closely with our friends in the faith-based community and also our partners at the state and city health departments, and we came up with the community engagement model. Through this model, we developed an approach whereby we trained volunteers to do HIV testing and linkage to care in the community. Volunteers went out and tested, volunteers linked people to care, volunteers educated, and worked hand in hand with us, and hand in hand through the expertise and capacity building of the state and the city to link people to care. We were so inspired by this work. Through the work of this community engagement model, we are able to have a presence in all of those places where you see the blue dots on that map. The dark places on the map represent the communities that are hardest hit by HIV in Baltimore. We're able to extend the presence of the University of Maryland to all of those areas through volunteers. Through this work, we were inspired to engage our academic campus. We approached partners at the School of Medicine and the School of Nursing with the idea that we would train medical students and nursing students to do HIV testing and linkage to care through their curriculum. We came to them with the goal to mobilize the academic and clinical campus, its clinical programs, and the surrounding communities to address the goals of the National HIV and AIDS Strategy. Derek told you about the National HIV and AIDS Strategy. It's very comprehensive. In our first year of our program, through 100 medical and nursing students, we were motivated by stories of personal transformation. Almost daily, we received feedback from students. Students saying, one case that stood out for me was a homeless man who was negative. It stood out because he said, "Thank you so much," when we were finished. All I did was be nice. It's a reminder of the discrimination that still exists in our society. Another student, PTF, Preparing the Future, has inspired me to think more about the value of personal relationships and psychosocial support in healthcare and overall wellness. Another student, while I was in the emergency department offering HIV testing and linkage to care, I came to realize my own personal bias and prejudice. As future physicians, we need to be more self-reflective. The impact of this intervention was much more than we ever imagined, and we realized that the students were a lot smarter than us. They realized before we did that it really did take all of the disciplines getting together and offering their complementary gift sets to address the HIV epidemic. This led us to our vision for 2013. We didn't want to just work with medical and nursing students. We wanted to integrate the PTF program into the curricula of all 6 academic disciplines on our campus. We wanted to foster interprofessional learning opportunities for students in areas hardest hit by HIV. And we wanted to then lay the groundwork for the routinization of HIV testing at the University of Maryland. We wanted our clinical settings to be ready for physicians, like the student that gave the quote on the previous slide that said, "We need to be more aware of our own prejudice and biases." That student is ready to go out into a practice setting and truly address the issues at hand. So the Preparing the Future program has truly made an effort to address the goals of the National HIV Strategy. We are aiming to reduce new infections, goal 1 of the National HIV Strategy. How are we doing this? Students are doing community-based outreach, education, testing, and linkage to care. This is all done by through volunteers and through students. Students are in the community offering HIV testing in interprofessional teams. They're working in the zip codes hardest hit by HIV in our city. And under the mentorship of the Jacques Initiative outreach staff and their faculty's supervision, they are using an approach that's comprehensive and addressing the psychosocial needs of clients as well. Through the addition of the disciplines of social work and law, we are truly able to assess the needs of the entire patient. Through the addition of the School of Dentistry, we are able to offer routine HIV screening at the School of Dentistry in partnership with the Jacques Initiative for linkage to care for patients that are identified with HIV. We are also working to routinize HIV testing at the University of Maryland Medical Center. We partnered with the Department of Medicine, and now when patients are admitted to a medicine service at the University of Maryland Medical Center, they are offered an HIV test by their doctor, by their physician assistant, their nurse practitioner, or their nurse. We are extremely proud of this partnership. And through their collaboration with us, we're able to link individuals to care that are newly diagnosed with HIV or previously living with HIV and not effectively engaged in care. The Preparing the Future program is also increasing access to care and improving health outcomes for people living with HIV. In the community, students are encountering people that are HIV positive and not engaged in care on an almost weekly basis. They are talking to these patients and assessing their needs. If that person has need of case management, if that person has needs of housing or substance abuse treatment, we're engaging them in those services through direct access from the community. Our students have a presence in communities that are disproportionately impacted by HIV. And as I said, we're able to integrate psychosocial support at the community level through the collaboration of the multiple disciplines on our campus. The Preparing the Future program is reducing HIV-related health disparities and inequities. Health disparities is a concept that we don't talk about all the time, but we really need to understand and know about. We are running an interprofessional community-based clinics. At Metropolitan United Methodist Church, community and public health nursing students have formulated a community-based clinic in partnership with Reverend Michelle Cheney and the surrounding community to feed people from the community, offer blood pressure screening, offer HIV testing and linkage to care on a monthly basis. We've also established a PTF clinic based at the Jacques Initiative, where patients are coming in and being served by students of nursing, social work, and law. We actually have the School of Law has a presence in our clinic weekly where they're serving the needs of people living with HIV. And lastly, to meet this goal to reduce health disparities, we offer interprofessional case conferences where our staff, students, and faculty get together and talk about cases and create and optimize plans of care for the patients that we're discussing in an interprofessional way. Ultimately, we believe that we're creating a more coordinated approach to the HIV epidemic, not only through the Preparing the Future program and the data and information that I just shared with you, but just by being here. We've articulated many, many times today already that each of you plays an important role in the HIV epidemic. I think that every single one of you is contributing to a broadened workforce and joining the movement. We're also launching a website today that you'll hear about shortly. That website is going to link us even further. You're going to be able to access resources on that website that are available across our campus to meet medical and psychosocial needs of your patients, to prevent HIV and to serve those living with HIV. I just want to share a little bit about the results and the outcomes of our program over the past year and a half. We've trained students from all 6 professional schools on our campus: nursing, medicine, pharmacy, dentistry, social work, law, and pharmacy. We are extremely proud of the collaboration between these schools. And this, like I said, has not been possible without a faculty point person in each of those schools that helps coordinate curriculum content. If you think creating coordinated schedules among students from 6 schools is challenging, it certainly is. But with a faculty point person and the coordinating work that we can do from the perspective of this Preparing the Future program, it is possible to get all these students in the same room, all these students to the same place in the community. The School of Nursing has truly led the way with 308 of our 500 students that have gone through the Preparing the Future curriculum. So we're very proud of the School of Nursing. They deserve a hand. Over the past couple years, every student that's come through our program has completed a pre and a post-test evaluation to assess their attitudes, knowledge, and behaviors that relate to HIV. In 2012-2013, we assessed a sample of 129 students from the 6 disciplines that I described to you earlier. And they answered true-false questions and Likert-style questions. We also did collected a great deal of qualitative data from these students as well. I'm going to share with you a little bit about the data that we learned from these students. First question, I don't know enough about HIV to have informed conversation with my patients or clients. On the pre-test, 45% of them felt that they did not know enough about HIV to have an informed conversation. At the post-test, 96% of them felt confident enough to share information about HIV with their patients. That shows that this program is having a positive impact on knowledge across 6 disciplines. Another area of evaluation. I'm able to discuss HIV in a culturally competent manner with my patients and clients. At pre-test, only 43% of people felt like they could discuss HIV in a culturally competent manner. In the end, 93%. All the results I'm sharing with you have statistical significance. I am comfortable talking about sensitive topics, including sex, with my patients or clients. At the pre-test, 67% felt comfortable. At the post-test, over 90%. Last week, one of our partners from Star Trek Adolescent HIV Clinic, Kate Bishop, did a capacity building session for students from 4 different disciplines on our campus in lesbian, gay, bisexual, and transgender cultural awareness. The very next day at Community, a Walgreens pharmacy, we were able to witness our students asking, are you sexually active? Tell me more about your sex partners. This person was calm. This person was at ease when they asked that question. I want that person to be my provider. I am or would be comfortable disclosing the results of an HIV positive test to a patient. At the beginning of our program, 24% said yes, and at the end, 57%. This is something that's hard to do for those of us that work in this field every day, but we are struck by the path, by the journey that students that go through this program go on. And lastly, and I think most exciting, at the beginning of a program we asked, I think it is too complicated to offer an HIV test as a routine part of medical care. At the beginning of our program, 85% of them said, no, I think it is reasonable to offer an HIV test as a routine part of medical care. And at the end, almost 100% of them said yes. This tells me 2 things. 1, routine HIV testing is important. And 2, this generation is the generation to go for. These are our students. They're a clean slate, and they are ready for this. So let's prepare them. Let's do this. Over the past year and a half, we've encountered over 4,000 people through community outreach and HIV testing among students from the 6 disciplines. We've worked at sites like Community, a Walgreens pharmacy, which has opened up its doors every week since September of 2011 for the University of Maryland students. We've been at Metropolitan United Methodist Church. We've been at the Redwood Pharmacy since the beginning of this academic year. And we're very proud of our collaboration with the School of Dentistry, where routine HIV testing is being offered to patients coming into the dental clinics. We've encountered 53 people living with HIV and 6 new HIV infections. And for every single one of these patients, we've verified if they're in primary care for HIV, and if they are not, we've made efforts to link them to care and have followed them for 2 medical appointments. I told you about all that qualitative data. We're very excited to be working starting in January to analyze the qualitative data and hopefully share that in the near future. I also told you about our collaboration with the medical center. The Department of Medicine is offering routine HIV testing to patients that come into the medical center. We've worked very, very closely with a very close multidisciplinary leadership team with the Director of Medical and Surgical Nursing. We've had nurse champions. We've worked with billing. We've worked with IT. We've worked with all different departments at the medical center through this leadership team to train physicians and providers and nurses to offer HIV testing and to create systems so that routine HIV testing can be routine at the medical center. Over 100 residents, attendings, and physician assistants have been part of this intervention. And as you can see as well, nurses, nursing students, unit secretaries, inventory technicians, and discharge facilitators have all been trained and sensitized to the routinization of testing at the medical center. So what's happened? This program started in March. We analyzed at baseline that 3% of patients being admitted to the medicine service were tested for HIV. The medicine service includes our infectious disease specialty service as well. After this intervention, which started in March, we were able to quickly get up to a 45 to 50% offer rate for HIV testing. That's on the left-hand bar. We learned at the very beginning that making the offer was very important because it worked. In our second month, we saw that 90% of patients were accepting that offer for HIV testing from their provider. We stayed at about 47, 48% for this first several months of this program. And through our leadership team of Dr. Tina Cafeo, Lucy Miner, Ruth Burkowski, and Dr. Mangla Galati, we were able to train nurses to offer routine HIV testing as well. And the offer rate went up dramatically. And as a nurse, I'm really excited and proud that in September, the offer rate for HIV testing on the medicine service at the medical center was over 80%. This work is very important. We've identified 16 new positives since March. We've also encountered over 300 previously diagnosed positives. 30% of those positives are not currently in care when they're admitted to the hospital. They're sick. They're going to be readmitted to the hospital. We're working with them at that admission to get them re-engaged in care, get them linked to the psychosocial services they need. Again, everybody has their something in HIV. Just some details about the newly diagnosed. 66% of them are men, 33% of them are women, 85% are African American, 31% are over the age of 50. Now, this is the part of the data that's extremely striking to me. Of the 14 that we have CD4 data on, 67% of them are AIDS defined, and they have very, very low CD4 counts. I'm really happy that we've been able to identify these cases of HIV and work to get these individuals into care. But this tells me that this campus can obviously do a lot more. What are the entry points on our campus? How can these entry points be mobilized to offer routine screening for HIV or help get patients get access to routine screening? How can we get people into care so they don't get admitted to the hospital with an AIDS diagnosis? We've been working hard to link individuals to care. Of the 16 newly diagnosed, 7 have been effectively linked to care. We're still working with several of them to get them into care. And of the out of care previously diagnosed positives, we're working hard to get them re-engaged in care as well. This comes with a very, very great collaboration with the Baltimore City Health Department. When we can't find people and get them into care, the Baltimore City Health Department works very hard to find them either in person and through their surveillance program. I'm going to turn this back over to Deborah Hickman at this time that's going to introduce a short video.
I think that Derek as well as Jamie deserve another round of applause. I don't know about you, but being a community member and in this room at this present time with Dr. Gallo, Dr. Blattner, with Jeff Crowley, and all of you, the leaders, my something is passion, commitment, conviction, and collaboration. Without those things, we will not do or go any further than where we are right now. But because of those things, we will do greater things. And so you have already gotten the rationale behind the achievements of the interprofessional work that has been taking place here at the University of Maryland. But this needs to take place not just here at the University of Maryland, but all across our city, all across our state. So we have a lot of work to do. And in order to do that work, we must understand the significance also of policy, the policy behind the routinization of HIV care, of HIV testing. We must do our part. And so I present to you this video, Preparing the Future, the routinization of HIV testing at the University of Maryland.
Mm-hmm. my name is Lynn Grant. I'm 59 years old. On June 10th of 2013, I was tested positive for HIV.
So Lynn, she was admitted on June 9th to the medicine service complaining of chest pain. She received a routine workup for her chest pain, and in addition, she got a screening HIV test as part of her routine laboratory workup. I was trained to offer all of my patients an HIV test as part of the Jacques initiative. I nearly discharged Lynn when I opened her chart and found that she actually screened positive for HIV.
I did very well, I must admit. I only cried one time.
Giving a difficult diagnosis is a challenge no matter if you're diagnosing someone with HIV or a terminal cancer or anything else. It's often difficult to convey the information to the patient. You too are upset. It's a heartfelt, emotional process.
I explained to Ms. Grant that, you know, this is just something new. It is devastating, but you're going to get through it. University of Maryland staff will develop a plan of care for your treatment, and as long as you stick to that, you'll be fine. You'll have years to live. This is not the end, it's just the beginning.
Then it was like just routine to get things done.
The Jacques Initiative coordinates a comprehensive linkage to care process that meets the medical and psychosocial needs of patients who are newly diagnosed with HIV and those who aren't currently receiving HIV care.
Ms. Grant presented to the Connected Care Clinic, and upon her visit to the Connected Care Clinic, she was given education about HIV, and she was also linked to services such as insurance, pharmacy assistance, and also supportive services that we provide here at Jacques Initiative.
When clients present to the Connected Care Clinic, they are met by friendly staff and a non-medical case manager. The non-medical case manager serves as the entry point into the clinic and begins to meet the initial needs of the client. These needs range from psychosocial to even scheduling the initial medical visit. The linkage to care process requires seamless coordination and the work of a multidisciplinary team that includes the physician and nursing staff of the inpatient units who ordered her HIV test and gave her the results.
Everything here is wonderful. I mean, the people are just, it's like family. You know, they're so friendly. Anything I want to know, they take the time to sit down and talk to me. Okay. My meds, okay, I'm doing great with that. I can't say anything bad because everything is just, to me, it's wonderful. It's like another family to me.
Through the routine testing of HIV for our patients who come to the University of Maryland, we as physicians, nurses, case managers, and social workers are able to educate patients earlier, educate families earlier, and also educate healthcare professionals as well to increase the awareness, increase the support we can provide to our HIV patients and help them live a long, healthy life.
When you see a doctor and staff that are just really 100% giving everything that they can to make people better, to genuinely make, not just make them feel better, but to genuinely make their lives better, you can see it, you can feel it. It's when you walk in the door.
The University of Maryland is committed to a comprehensive and integrated approach to the HIV epidemic. Through a multidisciplinary team of professionals, we are committed to making Baltimore and Maryland a healthier place to live.
Thank you to University of Maryland, basically because you didn't give my mom a death sentence. You know, you just gave her an extension of her life and basically how it just has to continue from now on. And we understand that.
We sure do. I have to say thank you as well, because like you said, it's not a new beginning, it's a different beginning. All right, and I feel wonderful. I have not felt this good in I don't know how long, to be honest with you, but I have to say thank you to the University of Maryland.
You're in my heart, I still love you. You're in my heart.
And while Ms. Grant is not here today, we do want to applaud her, but more so, I think that we want to applaud the providers at the University of Maryland Jacques Initiative. But we do acknowledge her because it takes a lot to go to your provider and to have them then to offer you an HIV test as a routine part of your medical care. And for readiness. Readiness is another big word. And so now I have the pleasure, the privilege of introducing a friend, a frontier, a runner up front during the time of the development of the National HIV/AIDS Strategy. I had lots of opportunity to go over to the White House Office on National AIDS Policy and to meet with Jeff Crowley, who was then the director of the Office of National AIDS Policy in their development of the National Strategy for HIV and AIDS through the National Black Women's HIV/AIDS Network. And so today I am very, very honored that while Grant Koufax, the current director, could not be here, that Jeff Crowley is here because July 13th, 2010 was a major day, and his staff worked very, very hard. He is currently a very distinguished scholar, a program director of the National HIV/AIDS Initiative of the O'Neill Institute for National and Global Health Law of Georgetown Law School. Please give him a warm round of applause and welcome, Mr. Jeff Crowley.
Good afternoon, everyone. It's a pleasure to be here with you today. I have to say, Reverend Hickman's one of my own heroes. She's doing such great work at STAR, Sisters Together in Reaching, but she also is really providing important national leadership. I also want to acknowledge Jamie and Derek, my good friends at the Jacques Initiative, for inviting me to join you. And also, it was a pleasure to be here with Dr. Gall. You know, I met him when I first got to the White House. It was the 25th anniversary of the discovery of the HIV virus. He invited me to join him on a panel at the Washington Press Club with him and Dr. Montagnier as they were sort of thinking about the course this epidemic has taken since the beginning, but also the breathtaking progress we've seen. So I think it's just great to know that not only has he created his own legacy, but it continues here at the University of Maryland. So my task today is to talk to you about your role in creating an AIDS-free generation. And I want to commend the University of Maryland for having a National HIV/AIDS Strategy implementation plan and for launching its Preparing the Future initiative. I have a confession. You know, in 2006, I actually didn't think the HIV community should push for a strategy. It's funny, I felt like, you know, the community should have asked for something more, but I also, you know, maybe I've been in Washington too long. I felt like we've seen so many blue ribbon commissions that release reports with great fanfare, and yet 2 weeks later they're gathering dust on a bookshelf and never to be seen again. So I have to say it was really a privilege of my lifetime to have been appointed by President Obama to serve as director of the Office of National AIDS Policy. I was also senior advisor on disability policy, but really to be given the task of developing a national AIDS strategy. And I have to say it was a daunting task. You know, we traveled the country and expectations were so very high. And so it's actually amazing to see that 3.5 years later, if you're talking about the domestic HIV epidemic, you're still really talking about the National AIDS Strategy. And it's amazing to come to a meeting like this. I mean, it's really actually incredible. I think the president provided important leadership, but the HIV community has just stepped up in a remarkable way. And so any success of this is not about what happens in the White House. It's really about what happens out in the world. You know, the federal HIV leaders across the government work together in new ways. I had people tell me that have spent their whole careers in the federal government that they worked with their partners across agencies more in the 6 or 8 months we were developing the strategy than they had the last 15 years. You know, so they stepped up, but also the HIV community stepped up. And, you know, maybe it's not right to admit to being proud, but, you know, part of this makes me proud that we did do something that seems to you know, still have some life. And, you know, sometimes I go places and I hear people say things like, well, I got that in the strategy. And my colleagues and I sort of chuckle to ourselves. We're like, really? Did you know they got that in? You know, but that's a great thing to have people feel ownership of it. You know, that's how we use something like this to really make change happen. So before I really get in, I want to, I often find it's useful. I live and I breathe this stuff. I know many of you do, but just want to give some baseline information about the HIV epidemic in the United States today. We have the most serious epidemic among developed nations. We have about 1.1 million Americans living with HIV and about 50,000 new infections. That's too many, right? We need to dramatically lower it. But we also need to acknowledge that's a sign of progress. You know, there was a point in the mid-'80s we had about 130 or so new infections. So we've made progress. It's heavily concentrated in key communities, gay and bisexual men, Black America, Latino America, and among substance users. I'd also say that, you know, gay men have always comprised the largest number and proportion of AIDS cases and the majority of AIDS deaths. But today, in some cases, as the epidemic is turning, it's becoming a gayer epidemic. We have gay men, our best estimates are roughly 2% of the U.S. population, represent about 2/3 of new infections. Now, the good news is that we've seen HIV rates stabilize and decline in every group in the United States except for young gay men. And that's, we're seeing increases among young gay men of all races. And I point out that it's most alarming is we've seen in just 3 years, from 2006 to 2009, a 48% increase in new infections among young Black gay men aged 13 to 29. But I think it's important whenever we give these statistics to point out, you know, we often equate individual behavior to their risk. And often on study after study, we know that these young gay men, Black gay men, often engage in comparable or less risk than other gay men, yet they're still at higher risk for HIV infection. So we shouldn't assume that, you know, they're screwing up or something. There are other factors in the world that are increasing their risk. The other thing when we think about, you know, ending an HIV epidemic, it's a numbers game. You have 50,000 new infections each year. Where are these infections occurring? And this chart shows about 85% of infections in the United States. All of these groups are high risk and all of them need attention. But if you look at these large numbers on the left, white gay men make up the single group with the largest numbers of new infections. That might surprise people. Sometimes out in the world we hear this rhetoric as though HIV has moved on from white gay men, it's affecting other people. Yet they're still the largest group. Followed closely by Black gay men, Latino gay men, Black women. We see a drop-off Black heterosexual men, white heterosexual women, Latinas, then Black male and female IDU. Now this next chart are the same numbers presented a different way. Here, and I would say it says bold, do not cite. You know, we developed this figure for the strategy, and I used new numbers for the number of infections, but I didn't have new estimates of the group size, so it's in some ways outdated. But even if some of this is wrong, it can give you a sense of the relationship. This is those numbers of new infections on the last chart, but then we divided by the size of their group, because you know there are a lot more heterosexual people in the United States than gay men, for example. So here we see huge rates of infection on the left, gay men, huge levels on the right, Black male and female IDU, right? So it's not to say we ignore the middle, but I think as we're emphasizing where we need to apply more resources. It shows all gay men are at high risk, but if we look at white gay men, Black gay men, Latino gay men, the rates for Black gay men off the charts. You could do a similar analysis in the Black community, you know, in different ways. Again, it's trying to give us some nuance about how we accurately and adequately target our resources. So, well, let's not get there yet. So now, I really wonder how many of you have come to this meeting today and said, this is an exciting time to work on HIV issues. You know, one of the observations I make is that too few people seem to recognize that great things are happening right now today, and also what great things we can make happen now and in the future. You know, I'd actually maybe be as bold as to say, except for that time in the mid-90s when we first got effective treatments, this is the most exciting time in AIDS history, that lots of great things are happening. So why, you might ask, am I so optimistic? And I think that three things are happening in potentially a synergistic way. The first is we have a national HIV/AIDS strategy, and by that I mean it's our first attempt to align what all domestic stakeholders are doing around a core set of high-impact action steps. We always said it wasn't going to be a catalog. It wasn't going to be a list of everything we need to do to respond to HIV. It's really about a concise plan for collective action. The second is that, you know, the strategy pointed us in a direction, but since its release, we've had some really remarkable scientific advances that have only bolstered the direction of the strategy. We've had the HPTN 052 study that Derek mentioned that's confirmed the effectiveness of treatment as prevention. We've seen the IPREX and Caprices studies prove the concept of pre-exposure prophylaxis or PrEP. And even if subsequent studies haven't found similar efficacy in other populations, we do know that PrEP works when used as prescribed, so we just need to figure out how to use it appropriately. And we've continued to make progress in other critical areas. There's, I think research for cures has been elevated on the research agenda. That's important. We're doing exciting things with regard to vaccines as well. But I'd say collectively, if this research has told us one thing, I think it's told us that we need to initiate treatment as soon as someone is diagnosed with HIV infection. And now, again, since the strategy was released, offering such immediate treatment is the standard of HIV care in the United States. And so now third, so if the strategy was a common roadmap and scientific research has reinforced the benefits of improved diagnosis and immediate initiation of treatment, access to care and treatment become critically important, right? And now we have the Affordable Care Act, or Obamacare, coming along. And while I know that the ACA won't solve all our problems, but by giving lots of uninsured Americans access to insurance, it creates a platform to make more progress in our fight against HIV. So you might think, oh, this is all lovely. It's an exciting time, progress is being made. But what does this mean in Baltimore, and what's this mean at the University of Maryland? So let me take you back to something the president said in the letter that he released when we released the National HIV/AIDS Strategy in July 2010. So I'm just going to excerpt a few things. He said, our country's at a crossroads. Right now, we're experiencing a domestic epidemic that demands a renewed commitment, increased public attention, and leadership. The federal government can't do it alone, nor should it. Success will require the commitment of governments at all levels, businesses, faith communities, philanthropy, the scientific and medical communities, educational institutions, people living with HIV, and others. Countless Americans have devoted their lives to fighting the HIV epidemic, and thanks to their tireless work, we've made real inroads. Now is the time to build on and refocus our existing efforts to deliver better results for the American people. And then finally, he said, I look forward to working with Congress, state, tribal, and local governments, and other stakeholders to support the implementation of a strategy that is innovative, grounded in the best science, focuses on the areas of greatest needs, and that provides a clear direction for moving forward together. Can you all see yourselves in the president's comments? I hope so. So now, without reciting the strategy, and I could do that for a couple hours, I won't. Let me say there are a few simple ideas. Let's refocus our efforts in the communities most heavily impacted by HIV. We need combinations of effective approaches to prevention and care. There's no magic bullet. We need a seamless system to immediately link people to continuous coordinated quality care. We need community-level approaches. To maximize our collective efforts, we need improved coordination across all levels of government and with all stakeholders. Now, much has happened since the strategy was released. The Centers for Disease Control and Prevention launched what they called the Enhanced Comprehensive HIV Prevention Planning Initiative. Long-term, it's called ECHIP, but it's commonly called the 12 Cities Initiative because it's in the 12 cities with the highest HIV prevalence, including Baltimore, and it was the first step to implement the strategy. CDC's also adopted a new funding formula for how they fund HIV prevention with health departments and to ensure that the federal resources follow the epidemic. This led to Baltimore being included for the first time as one of 10 jurisdictions that receives direct funding from the federal government to fund HIV prevention. And hopefully this will lead to strengthened local capacity, but also new and innovative partnerships between the state and the city to leverage the relative strengths of each level of government. We've also seen the implementation of the ACA proceed since the strategy came out. And while I was at the White House, we commissioned the Institute of Medicine to do some work on ways to better monitor HIV care and treatment. And that led the Institute of Medicine to recommend a set of core clinical HIV care indicators. And right now, the federal agencies are working to use those to align their indicators, streamline and really reduce these indicators, or what we ask of recipients of federal funding. One of the most significant developments, however, though, has been the popularization of the treatment cascade, which is, you've already heard this talked about. It's a population-level estimate of the care continuum from HIV diagnosis to viral suppression. Now, this is hugely important because while in some ways it didn't tell us things we didn't already know, it presents the information in a way that served to highlight where the health system does fairly well and where it does fairly poorly. The headline, and it's been stated already, is that 1 in 4 people with HIV is virally suppressed. Importantly, however, it shows us that these drop-offs aren't all equal, right? Indeed, once we get people retained in care, the right side, the health system does a fairly job getting all of those people to viral suppression. It's on the front end. So that means we lose more than 1 in 4 people with HIV who fall out of care after they've been linked before they've been retained in care. So this means we've done the hard work of diagnosing them. We've managed to get them to at least 1 medical appointment post-diagnosis, but for a variety of reasons, we haven't managed to get them to come back or stay in regular HIV care. We also lose a lot of people because we've diagnosed them, but we didn't manage to link them that first time. And as has been said, 18% of people with HIV are living with the virus and don't know it. And you know, this small group is responsible for about roughly half of all HIV infections in this country. So all of this suggests that to make progress, we need to find ways to get more resources and attention on the left side of this cascade. So this brings me to the Ryan White HIV/AIDS program. This was established in 1990 as an emergency response, but it's grown into a core part of the HIV response. It's the 3rd largest source of financing for HIV care after Medicaid and Medicare. It's the largest HIV-specific program in the United States. It's funded at nearly $2.4 billion a year. Now, some policymakers and some members of the public have been asking, are we going to need the Ryan White program after we have the ACA? I think that's a fair question to ask. But I also think we need to be emphatically clear that yes, because the ACA isn't taking over core functions of Ryan White. In fact, today, 70% of Ryan White clients have insurance. That's what this chart shows. This tells us that insurance, whether it's private insurance, Medicaid, or Medicare, doesn't meet all the needs of people with HIV, so they turn to the Ryan White program. So when we have more people have insurance, we can expect more people to turn to the Ryan White program for help with co-payments, help with non-covered services. But we're also going to need Ryan White to do the other things that it does, investing in health system infrastructure so that we have capacity to provide quality medical care in all parts of the United States. So now I really want to turn to the purpose of my remarks, and that's to make some suggestions for how you can work with the University of Maryland as it leads the way in implementing the strategy and creating an AIDS-free generation. But let me first mention remarks by the President on World AIDS Day 2011. So this was probably the President's most significant HIV-related speech so far in his presidency. He was at George Washington University speaking at an event for the One campaign, and he was joined by President Clinton and President Bush in other locations. On that day, he set new global treatment target so that without spending any more money, the United States said that it would set a goal of supporting 6 million people with HIV around the world on treatment by the end of this year. Think of that. That meant that he was committing that the United States of America was going to save the lives of 2 million more people. It's amazing. You know, he also made important new financial commitments in the fight against the domestic HIV epidemic. But you know what? In my mind, that wasn't the most important thing he said that day. Let me tell you what I think he said. The most important thing was, he said, so make no mistake, we are going to win this fight, but the fight is not over, not by a long shot. The rate of new infections may be going down elsewhere, but it's not going down here in America. The infection rate here has been holding steady for over a decade. There are communities in this country being devastated still by this disease. When new infections among young black gay men increased by nearly 50% in 3 years, we need to do more to show them that their lives matter. Can you imagine that? How often do you think presidents speak of young black gay men? And he didn't criticize them, pathologize them, chastise them. He told them that their lives matter. He also said, though, when Latinos continue to die sooner than other groups, and when black women feel forgotten, even though they account for most of the new cases among women, we've got to do more. So as the president has said, we've got to do more. And there are certainly other vulnerable and overlooked populations, including people dealing with addictions and other issues. But don't those 3 groups resonate you as people in your community for whom we all need to do more? So what do we need to do? The first, I would say that each and every one of you needs to take responsibility for fighting HIV stigma and finding a way to make sure that you show every person that walks on this campus that you care about them and you're here to support them. So I've worked in HIV a long time. And while I'm HIV negative, you know, I've actually worked at the National Association of People with AIDS. So many of my friends are positive. I feel in some ways I'm like an honorary member of the club. And I don't feel like people are holding things back or not sharing things when I'm around. But I have to tell you, if one thing surprised me when we were traveling the country listening to Americans to get their ideas for the strategy, was to learn about the depth of stigma and discrimination that people experience today. I heard of people talk to me about observational therapy. And when I asked them what that meant, they told me they had medical providers that were afraid to get close to them, so they stood on the other side of the room. Now, who really knows what transpired, right? Who really knows what transpired? But something isn't working for that perception to exist, right? We want people to be open about their status, but it can be hard, and it can have negative consequences. We want people to get tested, but in too many places, as soon as someone learns they're HIV positive, they're met with judgment and conversations about what they did wrong, right? So let's be clear. I am tasking you to fight stigma, but you're not starting from scratch. Remember, I've visited the Jacques Initiative. I remember the warm greeting by the receptionist. I observed how clients and staff interact with each other. So I think the first thing you need to do is make sure that what the Jacques Initiative gets right is translated across this campus. And remember, you can have the best medical provider in the world, but if the security guard or someone in the cafeteria is rude to you, you may not want to come back, right? 2, I think we need to commit to focusing on patient care and research into improving the patient experience. So I've already spoken at the Cascade and how we lose people along the way. We all need to do more in this area. That's, I think, our big challenge right now. So an HIV-positive friend of mine often speaks about how traumatizing it is to learn your diagnosis and come in for care, especially those first few times. You would say things like, because you're freaking out, and then you're asked to serially disclose to many people along the way at a time when you really just want to curl up in a ball. You'll meet a benefits counselor. Someone may draw your blood. You might see a nurse. You might see a doctor. You might be referred for mental health counseling. And each one may start the conversation. So your chart says you have HIV, right? That's challenging. Another colleague, and I have to tell you, as I was watching the last video, I was chuckling because I didn't know this was going to be showed, and so maybe it shows that you guys are ahead of the curve. But another colleague has talked to me about his work promoting active referrals on diagnosis. So instead of sharing a diagnosis and giving someone some papers and saying, here's a list of doctors, make sure you get to the doctor, what if instead someone says, you may not feel this way now, but you can live a long, happy, and healthy life with HIV. And that starts with getting great medical care. So you know what, I've made an appointment for you, and I'm going to come and get you, and we're going to go to the doctor together, right? His research has found that that helps people get linked and retained in care. So neither of these really is a specific suggestions for what you can or should do here. Rather, I want to task you with looking at your system of care, what works, but what isn't perfect. If your mother, your partner, your best friend came in here for care, are you certain they'd be treated the way you want them to be treated? How can you share what you know so that your great ideas are adopted elsewhere? So third, I urge you to ensure that HIV remains high on the agenda of priorities for this institution and this city. The fact that you have a national HIV/AIDS strategy implementation plan is huge. I'm just so proud of that fact. But we still have a serious epidemic in the U.S. and in Baltimore. So whatever role you play, make a personal commitment to working towards ending the epidemic. That could mean when research priorities are set, HIV remains prominent. It could mean when issues come up in a clinic, discussing the impact on people with HIV is part of the dialogue. Fourth, don't be afraid to talk about HIV. And this is advice I give every year. You know, part of the rationale for the National HIV/AIDS strategy was that we started doing amazing things for the PEPFAR program, the President's Emergency Plan for AIDS Relief, which is our global AIDS program. We're doing amazing things. But somewhere along the way, we stopped talking about HIV in this country. So whether it's in the cafeteria, at church, at your child's school, talking to your partner, don't be afraid to say the wrong thing, and don't be afraid to learn something new. But by not talking about HIV, I think a lot of young people aren't fully aware of their risks. But you know what? The other end of the spectrum, we're seeing increasing rates of HIV among people over 50. So maybe we need to find better ways to talk about healthy living and healthy sex in ways that work for older people. I don't have all the answers here, but I do know that few national challenges are resolved by being ignored. So I'll end by summarizing my own sage advice. Take responsibility for fighting HIV stigma, focus on ways to improve the patient experience, keep HIV on the agenda across this institution and across this city, and keep talking about HIV because it's still a pressing issue in Baltimore. So I have a friend, Phil Wilson, who's the founder and president of the Black AIDS Institute, and I'm going to poorly paraphrase him. He says that when the HIV epidemic is finally over, people will look back and they'll see we weren't all monsters. There were brave men and women who dared to love in the face of AIDS and dared to care. And you know what? Not only were we not all monsters, but there are lots of heroes, and many of you in this room, that have committed your lives to improving lives. So at the end of the day, the National HIV/AIDS strategy is just words on paper until people like you do something with those words. So I'm really grateful by the leadership shown by the University of Maryland to develop its implementation plan. But I'll stop with what the President said. We've got to do more. Thank you.
Jeff, thank you so much for your words and for your passion and for this plan. And we're proud that it wasn't just an exercise in futility. It's helping a lot of people. We're committed here at the University of Maryland to making a difference for people here in Baltimore and in Maryland. And we have two of our leaders here today who are going to come forward and greet us as it relates to our commitment. Dr. Lisa Rowan, I'm going to ask her to come forward, who's our Chief Nursing Officer. Is Dr. Bruce Gerald here? Come on, come all the way from the back. You get to make a grand entrance while Lisa's talking. Lisa, to you.
This is such an honor to be speaking today, and really, Dr. Gerald and I aren't speaking, but we are greeting. And I am representing Mr. Jeffrey Rivest, our Chief Executive Officer, and Dr. Jonathan Gottlieb, our Chief Medical Officer, and I, leaders of the University of Maryland Medical Center, and partners.
I thought you were talking.
Come up, I'm greeting. We decided to do this together and stand here together to really show visually how committed we are as a medical center and as a medical campus to really partner in a way that's integrated and that moves forward in that way with our students as well as with our clinicians at the medical center, and have with the goal of zero new HIV cases, 0 AIDS-related deaths, and 0 discrimination. And Dr. Gerald, would you like to say a few things?
Sure. Greetings. It's a pleasure to be here. I'm speaking on behalf of Dr. Jay Perman, who's the president of UMB. And I want to make a couple of comments, so I actually do want to make more than just a greeting. One comment is I was really struck by Jeff Crowley's discussion. There were many things in there that I didn't have in the front of my mind, and I think that every one of our students should have these things in the front of their mind when they interact with patients of all walks, with HIV, with other diseases, of course, too. You know, this program, the Jacques Initiative, is sponsored by the Institute for Human Virology, and I have been in the School of Medicine in various forms for 10 or 15 years, and it feels like each year I learned something new about the Institute. For sure, I've learned about a very deep commitment to basic science in the study of the AIDS virus. For sure, I've learned about the deep commitment that Dr. Gallo and associates have for the development of a vaccine for prevention. I've surely learned about their deep commitment to countries in Africa and Haiti and other places where HIV is clearly an epidemic and many patients are under care, and the deep fervor that those investigators have for those programs and those people. But I have to admit, I never appreciated the depth of the commitment to the Baltimore community that I learned about last year at this meeting and this year at this meeting. You have great depth and you have great breadth to the program here. And I guess now, having learned a little bit more even today, and when Derek came to visit me a couple of weeks ago in preparation for this, I guess I would conclude that silent waters run deep. I think I'd also conclude that they run with a lot of passion, and I've heard a lot of passion here today. And I guess I would say it's nice to be silent waters running deep, but maybe with so many people in this room, it would be nice to make sure that all of your efforts are being heard by a much broader population than just the several hundred who are here today. So I would hope that as you would expand your program, you get the word out about this great program in Baltimore. You know, universities thrive on many things. They thrive on our educational programs. We thrive on what great research we do. And I think if Jay Perman were here, he would say we also thrive on the things that we do for our community in preparing our students to interact with the community, as well as making sure that we view the community as part of the university, not those people across the street or whatever. So we have developed the attitude that you are our community, and so we want to make a deep commitment to that. Now, there are a number of topics that are already underway. You've heard a lot about interprofessional education, and you heard about nursing students and medical students and others working together to learn how to do team medicine. We've made a very significant contribution to develop such a center, and I think it's fair to say that we, along with you, will make sure that this is part of interprofessional education, that is, for the prevention and treatment of HIV. We've also developed now 2 new centers, one in global programs and one in local meaning Baltimore, which will formalize our students' opportunities to interact with the various communities, local or globally, to learn more about the care of this disease and how our students should be well equipped to understand the cultural, disease-related, and other parts of this disease. The third thing, I think, if anything, would be Jay Perman, his agenda. It would be also to say that we have a deep commitment to the West Baltimore community, which is part of this program. And we have certainly learned that good jobs are important. We have also learned that good health is important. And so as we develop our programs there, I will be sure to make certain that this initiative and other initiatives are part of that effort. So I guess I would say in closing that we look forward to continued partnership with the Institute, and certainly look for the leadership of the Institute to drive this agenda. I certainly would want to compliment Dr. Gallo, Dr. Redfield, Dr. Blattner, and now I'm learning a much greater, larger team than just the 3 of them for these wonderful things that you have accomplished with this broad attack. I certainly want to say that the university is supportive of this, and there would be nothing that would give me greater pleasure than to see Baltimore and the IHV University of Maryland initiative as setting the model for what a model community should look like across the nation. So it's my pleasure to be here, and I certainly champion what your agenda is. It's an important one. Did you want to say anything else?
I will just close with the recognition that as students, we frequently learn best practice. And we learn about that in the classroom. And then we enter the clinical world, and we are at the bedside, whether it be on an inpatient unit or in a clinic or wherever we care for patients. And we realize sometimes that best practice is difficult for all of the many reasons that our systems and processes present challenges. And so I encourage everyone to remember the best practice is our collaborative practice, and that in that way we will not lose our patients, and we will continue to find patients to link them to treatment. Thank you.
Thank you all very much.